It's my pleasure to serve as moderator for this session, and for everyone, just to make sure you're at the right place. We're in Racism as a Public Health Crisis. We have 3 speakers today, and what we'd like to, how we'd like to proceed is each will give their presentations. I'll give a short bio for each before they present, and if you wouldn't mind, if you have questions, please add them to the Q&A box, which is functioning, and then we can make sure everybody's question gets answered at the end. But we do ask that you ask questions, reserve your questions until the end. So without further ado, I'd like to introduce first Marshá Horton. She is Dean of the College of Health and Behavioral Sciences at Delaware State University. Dr. Horton is an associate professor, and I just said that. She is I have a couple actually of the same sentences here for some reason, and I apologize. She served as program coordinator for clinical studies at Wilmington University, where she was also an associate professor of education. She served as consultant in assessment, accountability, and public policy for the U.S. Department of Education and the Council of Chief State School Officers and Amtrak. She was also the Associate Secretary of Education for Assessments and Accountability for the Delaware Department of Education, where she coordinated the design and implementation of the Delaware Student Testing Program. There, she was also responsible for the department's teacher certification and licensure divisions, and she is president of the board of the Early College High School at DSU and a member of the boards for the American Conference of Academic Deans and the Delaware Foundation for Science and Math Education. She's a member of the Phi Beta Kappa, having graduated magna cum laude from Sweetbriar College and received her PhD in educational psychology from the University of Illinois. Dr. Horton was named a Living the Legacy honoree by the National Council of Negro Women, and on 2 different occasions, she was honored as an outstanding young woman of America. She's authored numerous articles and has presented at national and international meetings, and it's so great to have her here with us today. I'll turn the floor over to you.
Good afternoon. I'm very happy to be here with all of you this afternoon to discuss this important topic. Are you able to see the PowerPoint?
Yes.
Great. Okay, so my focus areas today will be racism as trauma, the cumulative impact of systemic racism, the juxtaposition of COVID-19 and health inequities, and a preliminary response to the question, what do we need to do to bring about a healthier Mid-Atlantic region, and what can we as organizations do to facilitate that vision? This summer, I was invited to be a guest co-editor for an issue of the Delaware Journal of Public Health. This issue was to be focused on the topic, racism and health. First, I want to thank the publisher, Tim Gibbs, and the editor-in-chief, Dr. Omar Khan, for extending the invitation. They made it clear from the onset that it was important to gather authentic voices to speak to this issue. And it was an honor and a privilege to work with them in this capacity. Now, typically when you approach reading or editing a journal, you think about the theoretical underpinnings for the journal in its entirety. This edition, like others before it, was thematic. The underlying theoretical underpinnings were not as important to me as the message that needed to be relayed and the importance of that message being relayed from various and diverse perspectives. I and my co-editor, Dr. Jackie Washington from the Value Institute at Christiana Hospital, were interested in including empirically based research and qualitative analyses, as well as editorials and personally based commentary. We also included a photo documentary and a graphic timeline of the relationship between race and health. Guest editors have the opportunity to provide notes as an introduction to the content. I felt it important that my notes be impactful. Specifically, I felt it important that readers knew that racism is traumatic and that what they were about to read would help them understand what that looks like, what that feels like, and how that is operationalized through the lens of healthcare providers, attorneys, educators, social workers, and health advocates, all who contributed to this journal. So why do I and many others say racism is trauma? And why is this type of trauma impactful for our health? Well, in the briefest of senses, trauma is defined as a physical injury or a deeply disturbing event. Trust me when I tell you that it is traumatic to repeatedly and consistently be subjected to a different set of standards and expectations. It is traumatic when I have to somehow prove I have a right to be in the room, regardless of whether the room is a high-end department store or a boardroom, an exclusive vacation spot or a members-only lounge in an airport, an Ivy League university faculty meeting or a private screening of a movie premiere. It is traumatic when my presence is questioned, my scholarly comments are disregarded, or my beauty is dismissed. And this trauma is not a one-time occurrence that you simply get over, that you heal from and move on. That is simply not possible because there are numerous and repeated occurrences. In addition, for African Americans, it doesn't necessarily have to happen to us personally for us to feel the impact. When we see incidents on the news or on social media, or when we hear of incidents relayed to us by friends or family members, we feel it. Let me draw a comparison. In this country, when people view the commercials put out by the SPCA or any animal protection group that shows dogs being abused, we feel bad. Those aren't our dogs on the screen. They are not even our neighbors' dogs. But we feel bad that the dogs are being treated so poorly, so we give. These organizations count on those feelings being aroused in their fundraising campaigns. For African Americans, the same thing applies when we see someone from our race being treated unfairly. Whether it's an unjustified shooting by police, or Black children being arrested at a neighborhood pool party, or Black athletes' dreads being cut off at a game because they were supposedly out of compliance with the dress code, or a 14-year-old being tackled by a woman who thought he had taken her phone. It's all egregious to us. It's all offensive to us. It's all deeply disturbing to us. It's all traumatic to us. Imagine if you suffer a cut to your arm. You apply pressure, the bleeding slows down, and just when it begins to coagulate, when it begins to clot, you're cut again. Again, the bleeding slows down, again, coagulation starts, but you are cut again. This process repeats itself over and over and over again. The new cut may not be in the exact same place on your body, but nevertheless, it's on your body. You can't fully heal because the trauma keeps reoccurring. To protect yourself, you become vigilant. You are on the lookout for additional attacks. You are in the fight or flight mode. As stated in an article posted by the Cleveland Health Clinic, your body tries to prioritize. So anything it doesn't need for immediate survival is placed on the back burner. That means that digestion, reproductive and growth hormone production, and tissue repair are all temporarily halted. Once the immediate danger is past, your system normalizes. At least that's what's supposed to happen. But in this case, you can't anticipate where the next attack is going to come from. But because of history, you are positive there will be additional attacks. This causes you to be in a continual state of hypervigilance. That means your body is constantly prioritizing survival functions. There are physical, behavioral, and emotional consequences of being in such a hypervigilant state continually. Couple that with the need to appear as if you're not being hypervigilant. You live in a world where you have to act normal. Life is going on around you and you have to function in that world. You end up operating in a parallel universe. In one world, you are living your life, going to work, going to the grocery store, enjoying vacations, developing relationships with colleagues and friends. In the other world, you're always on guard. You're always prepared for the surprise attack because you never know where it's coming from. Let me give you another example. The assault on the Capitol. The rallying cry was, "We were robbed." The thinking was, millions of people could not possibly have disagreed with our point of view. Our point of view is not only right, it is righteous. Therefore, because we must be right, we must have been wronged. And we have every right to fight for, to violently defend our position, and anyone or anything that gets in our way will suffer the consequences. We are no longer the law and order party. Law and order must be set aside if we have been wronged. Our fervent cries that Blue lives matter is no longer relevant. If those in blue get it our way, they too will suffer the consequences. We no longer believe in one person, one vote, and each vote counts equally. Our votes should count more. Our votes should be weighed more heavily. Our perspective is more valid. Your votes couldn't possibly be real. They must be fraudulent. Your votes don't represent real people. They represent people who really shouldn't count. Now, this narrative that unless my side won, then the election was stolen, was hyped for months. And it represented a sense of entitlement and privilege that is pervasive in racist mindsets. Where were the voices to say additional safeguards are in place to make sure that this election is safe and valid? We were concerned about interference from international players, let alone national players, so we made sure that our processes and procedures were protected and guarded. Where were the voices to say, we still believe in one man, one vote? Where were the voices? Okay, I've lost my line. Where were the voices to say, yes, vote. Get your mommies and your daddies, your uncles and your aunties to vote. But if our side loses, we move on. We accept it and try to work together for that more perfect union. Now, some of you may be thinking, wow, this has become quite the political conversation. This is far more than what I was expecting. My purpose is not to be political per se. My purpose is to clarify that these things do not happen in a vacuum. Seemingly unconnected events may in fact be very much connected. You may be asking yourself, but what does this have to do with public health? It has to do with public health because the differential responses to that incident have an emotional and psychological impact. Images of Capitol Police running for their lives, pulling comrades to safety from a riotous mob, being beat up by armed civilians, versus lines of military fully geared up on the Capitol steps in anticipation of marches by Black Lives Matter protesters sends a message. Just as police giving Dylan Roof a Burger King meal hours after gunning down 9 people in a Bible study sends a message. It sends a message that resonates in your psyche, a message that ends up being another layer of trauma. The trauma, the additional cut, may be personal, it may be individualized, or it may be structural. How many times does it take for a prospective small business owner to be denied a loan before he or she gives up? How many times must a potential home buyer be steered away from particular housing developments before they decide they just don't want to move? How many times must a scholar practitioner be denied a grant award before they realize their research is simply not acceptable enough for major funding? That's stressful. That's exhausting. That's traumatic. We all know that trauma has a real, tangible impact on health. Studies have shown that trauma has short and long-term effects on the functioning of our hearts, lungs, liver, and autoimmune systems, as well as on our mental and psychological health. It's no wonder that African Americans have higher rates of heart disease, cancer, high blood pressure, diabetes, strokes, and just about every other illness. The effects of this type of trauma are cumulative because there is little opportunity for healing. And the bottom line is, we are paying for the effects of that cumulative impact. If a segment of our culture, a segment of our society is not healthy, then our culture, our society in toto, is not healthy. We're seeing the results of that with COVID. Black Americans are up to 3 times more likely to die from COVID. That is not a coincidence. That is reflective of several factors. At the outset, it was harder for them to get tested, harder for them to be admitted, despite the fact that people of color are more likely to be in occupations that have now been newly deemed essential. In other words, these people are out there working, being in contact with the disease, while the rest of us are staying home to be out of harm's way. In addition, there are comorbidities that constitute risk factors for COVID: hypertension, heart disease, obesity, diabetes. These have combined to form the perfect storm of disaster. So what can we do? Let's start at the root. 1, This is not a Black issue. It is not a white issue, an Asian issue, a Latinx issue. This is a people issue. We cannot lose sight of the fact that what impacts some of us impacts all of us. We can stop looking at issues as if they don't pertain to us. Drilling down to healthcare, this country will not survive with separate healthcare systems, whether that separation is determined by income, race, or gender. It simply won't work. The healthcare system has enough problems already without adding another layer of issues on top. Number two, acknowledge that racism exists, but also acknowledge that it doesn't have to. Now, this is not meant to be a kumbaya moment, but stated by Ruby Bridges, the woman who as a young girl integrated in elementary school in Louisiana. Racism is a grown-up disease. Let's stop using our kids to spread it. In other words, we're not born racist, we're taught to be racist. We can stop that. Three, we have to be committed to change. It's not enough to empathize, sympathize, or criticize what is. We have to take action. And that leads directly to my fourth and final point. We have to do the work. We can't just talk about the problems. There is work involved and we have to do it. I work in an institution of higher ed, and as such an institution, what can we do to make sure that more Black and brown people are trained in the healthcare professions? Not just to be doctors and nurses, but to be social workers, business managers, HR professionals, medical, nursing, and physician assistants, home health aides, therapists, pharmacists, lab technicians, radiologists. You get the picture. But not only that, what can we do to prepare all practitioners to serve members of diverse communities? How can we prepare them for different worldviews and different cultural expectations that may impact how care is perceived and received? What can you, in your areas of professional expertise, do to further the conversation and further tangible outcomes? And how would you hold yourselves accountable for those outcomes? In closing, I think we all recognize that racism is a thing. It's not some imaginary or philosophical construct that exists only in the minds of the aggrieved. I hope by now you also accept that racism is traumatic, and thus it comes with all of the now well-documented impacts of trauma. The only thing left now is to confront that challenge and deal with it. Thank you.
Thank you so much. Just a little housekeeping note. There are people putting some stuff in the chat. If you have questions that you would like answered, please be sure to add them to the Q&A so I make sure to address all the questions that come up. And I'd say I would agree with some of that's coming up. This was an excellent way to open up this session. And the next speaker is Dawn Holden-Woods. She is Chief Social Services Officer for the Public Health Management Corporation and oversees the PHMC subsidiaries Turning Points for Children and The Bridge, as well as PHMC's Health Promotion Services Group and their Research and Evaluation Group. She previously served as Managing Director of Children and Family Social Services for PHMC and the Chief Executive Officer of Turning Points for Children. With Dawn's leadership, Turning Points for Children has grown to be one of the largest social services agencies in the region and includes the PHMC subsidiary, The Bridge. 4 community umbrella agencies also fall under Turning Points for Children as part of the Department of Human Services Improving Outcomes for Children initiative, which is responsible for the safety, well-being, and permanency of more than 5,500 children and their families. Dawn is the recipient of many awards and honors, including the Philadelphia Business Journal's Top Minority Business Leaders for 2020, the Philadelphia Business Journal's 40 Under 40, and Nonprofit CFO for the year. She is board member of the National Council on Crime and Delinquency, the Greater Philadelphia Chamber of Commerce, and the Committee of 70, as well as being a member of the Rho Theta Omega chapter of Alpha Kappa Alpha sorority. While no longer practicing, Donna is a certified public accountant and holds a master's degree in public administration from the University of Pennsylvania and a bachelor's degree in accounting from Lincoln University of Pennsylvania. So it's my pleasure now to introduce and turn over the floor to Dawn.
Thank you very much. Can you hear me? Perfect. So I'm excited to be here with you and really honored to have the opportunity to talk about such an important topic with two great panelists. I mean, Marshá, I was sitting here and for a second, I thought I was at church. I was tapping my foot. So this is great. And so I feel honored to have the opportunity to further this conversation. So one of the things that I wanted to really focus on was and is the definition of public health. And so according to the American Public Health Association, public health promotes and protects the health of people and the communities where they live, work, and play. And I just want us to ask ourselves, are we both promoting and protecting the health of Black and Brown people in the communities where they live, work, and play? And the reason I say that is because I think to many of the points that Marshá raised around COVID, that Black and Brown people die, we're 3 times more likely to actually die of COVID, I think centers around the point that we need to make sure that the solutions that we focus on and the policies that we roll out really center the needs of Black and Brown people. And so one of the questions I want us to think about as I speak today really includes the question of what would systems look like and how would organizations function if we as the nonprofit partners decided that it's our fault when solutions aren't successful with our participants versus blaming our participants for not engaging in the services that we offer. So, because again, when we blame the participants, we imply that the system was in fact designed for them, that it's sensitive to the needs, the unique needs of Black and Brown communities. And I would argue that all of our systems aren't actually set up to actually center that and address that. So one book that I read recently that I wanted to talk a little bit about that I think highlights how racism really doesn't serve Black and Brown communities well is the book Automating Inequality by Virginia Eubanks. I don't know how many people have read it, but the book focuses on how high-tech tools profile, police, and punish the poor. And there's a section in the book that specifically touches on child welfare, and which we all know is a social determinant of health, right? And so when we look at how we determine which families and which individuals actually need services, all of those indicators that we use, lack of food, lack of childcare, lack of transportation, lack of working utilities, lack of healthcare, are all issues of neglect. They're not actually issues of abuse. 75% of the calls that come in are around neglect. And these are all issues of poverty. So I think we just also have to acknowledge that there's an intersection between race and poverty and the ways that systems are structured to continue to perpetuate this issue. And so, one thing that I want us to think about as folks focused on public health is how our organizations show up in many ways in contradictory roles. The book talks about how we show up as both the provider of services and the investigators at times of maltreatment. And so those things at times are in direct conflict because we ask families to utilize additional services if they think they need support, but we also look at the number of times that families have accessed these services and we then choose to use that as a form of profiling. And so the book talks about and actually refers to this as poverty profiling. And one quote that sort of resonates with me is, like racial profiling, poverty profiling targets individuals for extra scrutiny based not on their behavior, but rather on personal characteristics, which ends up being, in this case, living in poverty. And the model explicitly confuses parenting while poor with poor parenting. And that's just one example, in my eyes, of how public health doesn't always show up for Black and Brown communities. So, you know, part of what we're here to talk about today is like, what should we do about this, right? And so one thing that I really early on wasn't too keen on, but I think is really important now, is that we work with our states, our counties, our cities to formally declare racism as a public health crisis. And I know there are some people who are sitting here thinking, Dawn, here you go. This is just more rhetoric. How many companies have come out, you know, after the murder of George Floyd to talk about their commitment to these issues, and nothing happens. But I still argue that if we don't actually state explicitly that racism is a public health crisis, we let people off the hook. And I think it's the first step in then having a conversation and creating plans and frameworks to actually address the issue. The second thing that I wanted to talk about related to that is, I think if we can have cities and states acknowledging that racism is a public health crisis, then we can also have very candid conversations about the fact that most of our systems we center charity versus solidarity, right? We think about charity, but we don't actually focus on root causes. And if we're going to really focus on a race-based agenda for public health, then we have to acknowledge that we should stop delivering services, stop giving people more services. It's not that the families and communities we serve need more services. We need to focus on capacity building and partnership with communities. And we need to also ensure that the dollars we receive are flexible and can actually, and are actually resourced at the levels we need to ensure that we can be effective in our work. And I think we have to be bold and step away and decide to stop delivering services that we know aren't appropriate, because in many ways we're complicit when we do that. We continue to deliver services that we know will never actually get to the outcome that we all want, which is equity. And so I think we just have to acknowledge that racism is a public health crisis, that we need to look at how our work and our systems are resourced. And we also have to decide that we'll stop, as providers, we'll stop delivering services if they don't actually meet the needs of the communities that we serve. Another tool that I've been following that I think is interesting, it's active in Oregon, is this notion that cities and municipalities should actually also include, as a part of the budget process, a racial equity budgeting tool. And here again, it's tied to the first statement around racism, declaring racism as a public health crisis. I think we also need to look at the dollars, the investments in community. We also need to look at what happens and who do we generally center, or who do we decide isn't important when we make municipal budget cuts. And so in Oregon, if you go to their website, they have a race equity plan, but a part of that plan includes forcing each department to look at, if they are making a cut or advocating for more revenue, how will this actually advance equity? And I think we just have to be very clear and very explicit about it. And I think we have to ensure that we force government to have these tough conversations, because if once we move out of COVID, we know that cities and states, you know, are losing revenue right now. We know that, you know, there are budget deficits looming, you know, at every level of government. And generally the next part of this conversation will end up being closing health centers and community, eliminating after school programs. And we know that all of these cuts, we know, will further impact Black and Brown communities. So just wanted to make sure that we point that out as a second piece of what I think is something that we can do in a tangible way to really make strides. And the third thing I just want to talk about is ensuring that we use data and center data as a part of our conversations and the agendas that we set forth and advance around public health. You know, so much of our work centers around organizations and individuals putting forth solutions that aren't actually rooted in science, that lack data. And the second piece of this conversation is, I think we also need to ensure that the data that we put forth is evaluated by Black and Brown researchers. And I say that because we know that the lens by which we view information and the people who are also contributing to this science, we come up with different solutions when we make sure that we have diverse perspectives as a part of this conversation. I also think it's important to make sure we have data. You know, at PHMC, we're fortunate to have a household health community database that has over 40 years worth of data and trends. So we really can look at neighborhoods over time, and not only just neighborhoods, but really census tracts and pieces of zip codes. Because oftentimes when we look at aggregated data, we may say, well, 30% of people in this zip code, you know, have diabetes or have unmanaged diabetes. But if you look at this information and you drill down even further, we're really talking about 95% of individuals living in very specific pockets of neighborhoods are living with these chronic diseases and conditions that we need to address. And so I think we need to ensure that we're using data to inform our advocacy efforts, to inform all the arguments that we make for new services, and that we also spend time focusing on community engagement and rallying together complex coalitions of stakeholders, more importantly, and most importantly, grassroots organizations, to make sure that we're getting the information out, that we're being transparent with community around both the issues and our work in addressing and partnering with them to solve some of these problems. And I think that should be our focus. We don't really need another demonstration project. I mean, most of us know what works and what doesn't work, but we're also just not sharing this information with community and ensuring that it's driving decision making. And the last point that I would make there, and I know this is something that Jessica plans to talk about in her presentation today, is also the importance of philanthropy and how they also are complicit in the outcomes that we see in community. And the fact that we're not moving the needle is because philanthropy isn't always being intentional with the investments that are made. Oftentimes folks make short-term investments when we know that we have to have solutions that are 5, 10, 20 years long, but will oftentimes resource an organization for 3 years to solve a complex problem, at which point we know we won't be able to actually really fully see the change that we want to see during that time. And so I think it's important that we work with philanthropy to solve these complex problems. And so as I, wrap up my remarks around, racism as a public health crisis, I really just want to share a couple of quotes. And these things also resonated with me when I was looking at many of the images that Marshá shared. Is one thing that Rep. Jeffrey Sanchez from Massachusetts, former Rep. Sanchez, mentioned in an article that I read, Racism, and he just pointed out that racism has been killing people for a really long time. And so I just want us to be mindful that, racism didn't begin with the murder of George Floyd. And then the last thing is something that was said by Tony Evers of Wisconsin, which was, just like we cannot look away from police brutality and the killing of Black men and Black women, we cannot look away from the reality that inaction, indifference, and institutional racism has harmed generations of Black and brown Wisconsinites, since that's where he's from. And we can argue Black and brown people. And so I just want to ensure that each of us here, in whatever way we can, we're ready to focus, get into action, and to do something, because inaction and indifference also makes us part of the problem. So thank you so much. I appreciate having the opportunity to just talk briefly about this topic, and I'm excited to hear what Jessica will share next.
Thank you very much. And that was a nice segue into Dr. Owens-Young's presentation. Jessica Owens-Young is an assistant professor in the Department of Health Studies at American University. Her work broadly focuses on social and economic inequities, structural racism, and its impacts on health in Black communities, such as maternal and infant health. Prior to American University, Dr. Owens-Young worked as a program associate at the Annie E. Casey Foundation, and she completed her PhD in health policy and management at the Johns Hopkins School of Public Health, specializing in health and public policy. So it's my pleasure now to turn the floor over to Dr. Owens-Young.
Thank you so much, Heather. And thank you, Dawn, for that nice layup that you just gave me. And everyone can see my screen properly, right? Okay, cool. So the title of my talk is Structural Racism is Trauma, really focusing on the implications for philanthropy and advocacy from a public health perspective. And so what I want to do with this talk is really first ground us in what structural racism is. You know, a lot of us are familiar with interpersonal racism or instances of individual level acts of racism, but I come to this topic from a structural lens. I also want to connect the concept of structural racism to this idea of trauma that Dr. Horton talked about earlier. I will also present just a bit of data that looks at patterns in philanthropic funding to address mental health in Maryland. And I'll discuss the implications for philanthropy and advocacy. So as I mentioned, I come to this work using a structural lens. And what this means is that racism is a feature that is embedded in the different social, political, and economic institutions that we engage with daily and throughout our lifetimes. And so I think about how institutions such as education, transportation, recreation, the justice and judicial systems, and even how our own neighborhoods are designed to create structures in which we live, work, play, and pray, and how that influences our health. Another feature of structural racism is that these systems reinforce each other, right? And so an example that I often think about is this idea of the criminalization of young Black girls, especially in educational settings. So for example, how we can look at data and see that young Black girls within the school systems are often targeted at higher rates for disciplinary action. They're also more likely to be referred to the guidance counselor, school counselors, and principals for behavioral concerns because of the lens in which young Black girls are viewed. And this system is then connected to the justice system, right? We often see that schools have school resource officers that may arrest young Black girls for behaviors that, if seen in other racial groups, would not have warranted a response from a police officer. And so when I think about structural racism, it's not just looking at systems alone or by themselves, it's also looking at how our social, political, and economic systems are reinforcing each other throughout our lifespan. These systems are also created by people, right? This isn't a natural occurrence in our society. I think of racism as a structural feature, not a bug, right? These systems were created from results of decisions, decisions made by humans with social political power. And so that's just an overview of how I approach public health and racism using a structural lens. Now you connect structural racism to this idea of trauma that Dr. Horton talked about earlier. And when I think of trauma, often the first thing that we think about are individual acts, or something has happened to a person that has caused them some type of harm. Now, from a structural level, we look at how systems may cause harm to populations. Okay, and so when I think of structural trauma, I think about repeated exposures to stress due to the structural factors. And so some examples that I outlined here range from economic, educational, environmental, and the justice system. And so I'll focus on just describing one example. So an economic system that may serve as structural trauma could be the fact that Black women make less income for the same job and often, doing more work than their colleagues, than white males and white women, right? Or the fact that Black families have more difficulty in passing down wealth throughout the generations, which then causes its own form of stress over time. And so structural trauma isn't just one individual act that may have harmful effects. It's about how different systems work together to create harm across the life course, even before we are born. So I've been thinking, as many of you probably also have been, thinking about the effects of the COVID-19 pandemic. And so when I'm thinking about COVID-19, since I live in Maryland, been a Marylander my entire life, I think about how the COVID-19 pandemic has really impacted Marylanders. And one thing that I have been talking about with colleagues and family members and friends is how COVID-19 is the great exposer. I remember at the beginning of this pandemic, many folks in the media were talking about how the pandemic is the great equalizer, that everyone was going to feel its effects equally. And as we have seen over time, that has not been so. And many of us probably thought from the beginning that no, this great equalizer metaphor is not going to work in this pandemic. And why did we know that? Because we know about the pre-existing social inequalities and inequities that have plagued our society since the country's founding, right? And so understanding that there are already pre-existing social inequities that contribute to health, right? Through this idea of the social determinants of health, that this pandemic was not going to be the great equalizer, okay? And so I've been thinking about this over time, and I've been thinking about this even more so when a study came out in December. And so I came across a study titled Racial Differences in Statewide Suicide Mortality Trends in Maryland During the Coronavirus Disease 2019 Pandemic. And this study examined racial differences in suicide rates before and after the lockdowns in Maryland. As you can see, this interrupted time series analysis shows that prior to the pandemic, there's pretty equal amounts in suicide rates, even a spike prior to the first reported case in Maryland among the white population. But after Maryland shut down, we see an unexpected increase in suicide rates among the Black population in Maryland, and again, an unanticipated decline in suicide rates among the white population. And so when I read this study, I really connected this with, again, the idea of the pre-existing social conditions that could be contributing to this mental health concern, this traumatic outcome of the COVID-19 pandemic. And so these trends aren't biological or genetic, right? These trends have to do with the social conditions in which people are living and working and playing and praying. And if you think about the lockdowns, not just in Maryland, but across the country, the lockdowns really affected a particular type of work in which people of color and Black people in particular are overrepresented, right? And so the lockdowns really affected the service industry. And this is often the only source of income for many people, and you are not really able to do this type of work at home. And so one theory is that due to the type of work that the Black population in Maryland is overrepresented, that was really impacted by the lockdowns, these social conditions may have been a major contributor to these outcomes that we see here. And so I connect this with, again, the idea of pre-existing social conditions. And I'm sorry I can't make this bigger, but this is really a table of racial differences in median household income throughout the counties in Maryland. And for the most part, prior to the pandemic, this is data from the 2020 county health rankings, but they use 2018 data. Prior to the pandemic, we really see racial differences in median income. Now, why is this important? Median income is often tied to our ability to access health promoting resources. And so it's also related to our ability to create wealth and to create savings. And so if you are in a state that is experiencing a lockdown and you're unable to work from home and you may not have a lot of savings to rely on, this is a traumatic event that's caused by a structural problem. So what does this have to do with philanthropy? And so I come from a philanthropic background before becoming a professor at American University. And for the sake of this presentation, philanthropy is really referring to those private foundations that conduct grant-making activity. And so when I talk about philanthropy throughout the rest of the presentation, I'm not referring to federal funders like NIH. I'm referring to those private foundations like the Robert Wood Johnson Foundation, Annie E. Casey Foundation, whose mission is to engage in grant-making activities to promote some type of social change. And so mental health is related to the social structures that shape our lived experiences. And those social structures are related to policies and systems that are the result of policies. And I focus a lot of my work on philanthropy because this type of organization is in a really unique situation where they are able to use their assets to influence different sectors that shape public health, from research to supporting organizations that provide programmatic activities for their community. They can support knowledge translation and dissemination. And perhaps most important to me is that philanthropy is also in a unique situation to support policy and system changes that may address structural racism. And so I looked at some data from funders using the foundation directory online between 2010 and 2020 to just examine how have funders addressed mental health care in Maryland. And so I looked at how much was funded, how many funders there are, and how many grant organizations receive funding. And as you can see here, between 2010 and 2020, the average amount per grant to address mental health care in Maryland is $55,797, right? I don't have data for how long each grant was for, but we know that most of the grants that are granted for public health work really last between 12 months and maybe 36 months if you're lucky, all right? Then I wanted to look at how are these grants specifically targeting or servicing African-American and Black populations in Maryland. Now you see the numbers drastically change, right? We go from 314 funders to 5. We go from 4,500 grants to 29, right? And the average grant amount also declines from 55,000 to 48,000. Okay, and to me, this is a form of structural racism within philanthropy. Okay, I can go into details about some limitations of this analysis later, but the broader picture is that if we are targeting addressing racial inequities, our grant making should be specific to that type of work. And like I said, I could talk about that later or answer questions offline. So the last thing I wanted to look at was how many grants were specific for policy advocacy and systems reform related to mental health care in Maryland. And here, we still have a decline in the amount of grants, and the average dollar amount per grant declines from, again, $55,000 to $32,000. Many of you are advocates, many of you have engaged with the policy systems, and you know that policy work takes a lot of time and it takes a lot of money. And to me, looking at how much grant-making dollars are given to policy work related to mental health care is really telling about how philanthropies are looking at what's important to support when addressing mental health in Maryland. So just a few implications of this type of work that I do. I think this type of work helps us think about how we can better educate funders. How can we help funders make connections between structural racism and trauma and increase their funding for policy and systems changes? Again, because those structural factors that influence racial inequities, structural racism, and health outcomes are policy related. I also like to think about how we can imagine funding strategies that are based on a trauma-informed framework, right? And again, we're in the audience, we're not just recipients of grants, right? Many of us are, but many of us also sit on boards of foundations, or we work with foundations as consultants or advisors. And so we should reimagine how we can influence philanthropic practices that take a public health view for structural racism and trauma. And so that's really my concluding points for this presentation, and I'll wrap up there. Again, just emphasizing that structural racism is a system of trauma with social political roots, requiring policy and systems changes, and that we as public health professionals can work with funders, not just as grant recipients, but also as influencers to help them reimagine funding with a trauma-informed framework. So I'll stop sharing my screen there.
Thank you so very much to all of our presenters. I think really the thread that has been emphasized throughout is the role that racism plays as a fundamental component of health. And it's clear that this is important work that all public health professionals should be engaged in, whether they're in academia, in a community-based organization, providing some sort of social service, or if they're working with funders. We do have a couple of questions that have come up. The first, I think, actually was directed to Dr. Horton, and this is from Francine Baker. She writes, "The idea that racism is traumatic is such a foreign thought for those who don't acknowledge the existence of racism. If you're always on the other side of racism, how do you even connect to this idea that racism is traumatic?"
So one of the things that I tried to do in my presentation was to draw analogies, because you're right. If you haven't experienced it, it's hard to for people to understand, for people to wrap their heads around it. And so that's why I took the point of the cut on the arm, the sad little puppy dogs. I mean, in this country, we can get really worked up about animal rights. And I remember something very telling. I remember when this lion, I don't remember the name of the lion, was killed, and the country was all in uproar, and I was right in uproar with them, thinking, how could you kill this royal, king of the jungle? And then some people from Africa said, well, okay, well, we're not concerned about that, because in our world, they eat us. So it's really not that, not that same thing. And it's different world perspectives. And so it really starts for me at the individual level, having the conversation, because people who are not of your same ilk, whether that ilk is culture, gender, race, ethnicity, socioeconomic background. Have the conversation with them and say, okay, well, tell me how you feel. Listen to what they have to say, but talk to them about your own experiences, what you've seen, what you felt. Now, see, I grew up in a segregated city in the South. So, I grew up in the capital of the Confederacy, Richmond, Virginia, Monument Boulevard, so I have a very different set of experiences than people who were born later. But the point that I was making earlier is that that was just not a one-time deal. This is continuing. And so in order for people to really understand, I think it starts with conversations. So that's the short answer. Have the conversation. Tell them what you've experienced and why it makes a difference in your life.
Mm-hmm. Another attendee asks about the reasons that push people to be racist. So generally, I don't hear much about this, and I think these reasons could be crucial in doing the work to dismantle.
So the same thing. People have their own reasons for feeling the way that they feel. And some of it has to do with just really listening to one narrative. So for example, I try to listen to multiple news media because, the media will say, well, we're being very objective. No, you're not. Everybody has a lens. And you need to listen to those other lenses to understand why people are thinking the way that they're thinking. The same thing holds true for people who are racist. They don't consider themselves to be racist. A lot of times they're considering themselves to be protectionists. They're protecting their values. They're protecting their families. So the conversation, so why do you feel you need to protect? And what are you listening to? What are you hearing that makes you feel that this group are the ones you need to protect yourselves from? Now, the other point was if you grow up hearing this stuff, it's hard to unentangle it until you have some firsthand encounters that contradict what you thought you knew.
Absolutely. A couple more questions.
So can I add something to that?
Oh, absolutely.
Yeah.
I'm so sorry.
No, sorry, I didn't want to interrupt. But when Dr. Horton mentioned that everybody has a lens, right? And these lenses are also shaped, again, by the systems in which we find ourselves. So, for example, if you're working in an organization that has particular policies and you're acting towards or in a way that meets those policies that have racist outcomes, you yourself may not view yourself as a racist, right? But you are engaging in practices that uphold racist outcomes. And I think that's something that people should be aware of, because often we just go and do, our daily business. We just say, this is what we were told, this is how it works. Sometimes we have to challenge those assumptions behind those policies that shape our work.
Thank you. Francine also asks, what forms of funding are available for young adults just entering the workforce interested in starting their own business? And what advice would you have for a young Black entrepreneur? And I maybe we need a little bit of clarity there too. So maybe starting an own business to help dismantle systematic and interpersonal racism, or just any business. Maybe the speakers have better insight than I into this question.
When I saw that question in the Q&A, I was thinking about funders and how they support workforce development programs, and how often the design of these programs are really trying to get people in pre-existing opportunities instead of supporting people in creating their own business opportunities within communities. And I think that's something that we should encourage funders to do, to understand that preparing people for work isn't just about getting them into organizations that already exist or that positions that already exist, but to tap into the entrepreneurial spirit that many community members already have. And I think for me, that connects to this idea of dismantling structural racism, because often the solutions for these social issues are already within the communities, and that they just need the resources to help fulfill the visions they already have, or to support the skills and assets they already had. And so, I mean, I might be rambling now, but that's what I thought of when I saw that question.
Thank you.
Now, one thing you can do, and I do this for anyone who's looking for money, is Google. You know, you can really just do some searches looking for funding for startup businesses. But the other thing you can do is reach out to the institutions of higher ed that may be in your communities, because one of the things that they are doing, they are trying to assist the communities in which they reside in various areas. So I know, for example, that the College of Business here at Delaware State University is starting up some different initiatives to help small businesses get started. What resources do you need? What information do you need? What type of wraparound? So, you know, so reach out to the institutions that are in your area. If they, particularly if they have College of Businesses or schools of business, and, you know, try to talk to someone who's in that dean's office, because they're more likely the one who's going to know what the specific initiatives are, to say, I'm interested in starting a small business. Do you guys have any resources, or can you refer to me some, you know, and you never know what you may find out. They may be interested in partnering with some businesses just to help you get started.
That's a really great suggestion. I know in Philly too, Temple University's Fox School of Business does something similar, and they have a whole program specifically for small businesses and entrepreneurs. So great suggestion. For Dawn, when looking at a system such as the child welfare system, is it possible to address systematic racism from within, or do we need to dismantle and rebuild entirely?
Ooh, that is a tough one. I mean, I tend to probably be more of the mindset that we need to dismantle some of these things and start over. And I mean, I'm a realist, so I understand it's not as easy as just walking in tomorrow and eliminating what's there and rebuilding from the ground. But I think every time we've approached reform without, I think, taking a really bold position, we end up with Band-Aids. So, and then the second thing is we don't often end up with new thinking. Or if we do, the system generally will push people who come with very different ideas and approaches out. And so we end up really only continuing to remain with the old guard, which generally has a singular sort of way of thinking and approach that oftentimes is tied to, as we know, organizing, unions. I mean, it all gets very complicated when you start to think about how do we sort of dismantle and make changes. So I do tend to feel like we need to sort of make some really bold changes and start over. But I mean, across the country, there certainly, I think, are places where people have been innovative. Government has been innovative. I think there, though, when I think about Philadelphia relative to some other places, our system is very siloed. So like child welfare is separate from behavioral health. And so I think where I've noticed the most progress tends to be in places where those things are all bundled under one, you know, leader who has the capacity to sort of move pools of money, braid and blend funding together. So that's just sort of my thought there.
And then this question, I would say, is for all of you. Are you hopeful that this movement toward racial inequity, or actually racial equity, is going to affect change rather than past movements or attempts? So what is your perspective on current events and their impact?
So honestly, when things first started, I was not, because I've seen other movements come and go. That has changed for me, and I think primarily because it has sustained itself for such a long period of time. I am optimistic. I think we as a nation are at a point where we have seen what can happen when we don't address things, and that people are of the mind now to do something different. And that different applies to social justice, that difference applies to public health, that difference applies to a number of social ills that I think people now have the motivation and the incentive, and they've had time to be reflective to really make a change. So yes, I am hopeful, I'm optimistic. I am paying attention. I'm not, I want to say I'm vigilant, but I am paying attention and willing to add my voice to that, willing to add my labor to that.
I would agree with Dr. Horton. I label myself as cautiously optimistic. I think most of my optimism comes from working with young students, to be honest. You know, hearing how the students in my classes are talking about these social issues, knowing that they are going to be the next generation of leaders, makes me hopeful and optimistic. I am also encouraged by the use of language that has changed. You know, often our work can't really be changed until how we talk about it changes, right? And so to hear people in positions of power to actually use the term structural racism or even just racism, to see governors, you know, as symbolic as it may be, and we can have another conversation about that at some other point, but having governors or other civic leaders declare formally that racism is a public health issue is also very encouraging to me. You know, offices of minority health, you know, often started back in the day from just a simple statement from the legislature, and then they became institutionalized over time. And so seeing these state leaders, these even city level leaders first begin with institutionalizing the idea that racism is a public health problem through statements that will live on through time is really encouraging to me.
Dawn, did you want to add anything?
No, I think Jessica shared my thinking. I'm all too cautiously optimistic. I joke sometimes. I sometimes I refer to myself as Dawny Downer when I feel like I'm when my glasses half empty. But I'm certainly feeling cautiously optimistic, and I do also agree that I think young people are ready for a different experience, and so I think their continued sort of focus and diligence around this work will yield some different outcomes in the future.
This last question is for Dr. Owens-Young. So regarding grants and funding, did the projects you looked at actually try to address or study interventions to reduce disparities, or were they projects that included minority populations?
Yes, it tended to be the latter, either targeting specifically, well, those few grants that specifically target African American or Black populations, but not necessarily specifically reducing racial inequities or really targeting racial inequities in their work. But I think that is a trend that's going to be reversing in philanthropy. Often now you see in calls for proposals, funders are really asking about grantees' plans to address racial inequities, regardless of if it's mental health care, if it's food systems, you know, across the board, we're starting to see funders really require some good thinking and analysis and even work around racial inequities. And so, yeah, this set of data really hasn't captured that, but I'm hoping that over time, we'll start to see more and more grant projects specifically to reduce inequities.
Thank you. I have a question, and I think it builds off of a lot of what has been said already. So declaring racism as a public health crisis is certainly, you know, a necessary first step. But what would you say is most critical to dismantling racism in the U.S. today? Where should we be focused?
So this, Dawn.
Go ahead.
Well, this country has such a long history of, I don't want to say sweeping it under the rug, but not confronting it. and not calling it what it is. You know, it's like, and I think the conversations that we're having now is a step in the right direction. Repeat the question again, Heather.
I'm curious as to what you think is the really most critical call to action for people and what we should be doing maybe as a profession to move the needle on racism.
Okay. So but the second part of that, you know, is really taking a look at where you are in your professional realm and asking the question, what can we do? So we can talk a lot about well, let me tell you what they should be doing and what y'all should be doing. And what are you doing? Okay, what are you doing in your world to change this? And it could be something small, it could be something big, but if all the smalls get together, then you have a change happening. And having those conversations, like Jessica was talking about, you know, bringing the issue of equity into the room and having the conversation, not just to say, well, yes, we realize so and so and so and so, but, okay, no buts. We realize so and so and so and so and so, and this is what we can do to address it. So making it foremost in our thinking, in our policy planning, in our conversations, in our operationalizations of issues, I think is what's something that can be done.
The only thing I would add, or I guess one thing I would add, and I see some folks have dropped it, one of my colleagues actually at PHMC has dropped it in the chat, is I would also say focus on economic mobility, because we know that race and poverty, right, are also commingled and intertwined. And so I think in order for, I think race and just for things to change for Black and brown people, like we have to have that conversation and figure out like what we are going to do about that. And I think the only other thing that I feel really strongly about is making sure that systems are designed by the people who will receive the service. I mean, I think like we will also see changes when we have Black and brown people designing the system, you know, and I think dismantling and redesigning the system and redesigning every part of participant experience, be it in a hospital, in child welfare services. Like I think we'll begin to see, you know, changes when there are equitable policies, equitable organizations, and that we really sort of center race in everything that we do. But I think if we don't focus on wealth building, we'll be here 20 years from now with having this exact same conversation.
That's an excellent point. And I just want to draw a funny analogy in terms of having us be the ones to design the systems. Every time I get a mammogram, I think a woman did not do this. Okay, if a woman had designed a mammogram, it would not be this experience. So it's the same type of conversation in terms of what Dawn was saying. We need to be in the room designing the structures.
Agreed. And for me, starting with building economic wealth and addressing economic situations, not just beyond poverty, but specifically wealth, right? Because we see even when Black folks, particularly Black women, are achieving higher income levels, right? They're in the middle class, they're in the upper middle class, or even towards the 1%, right? We still see these inequities in health outcomes, right? And so it's not just about getting people out of poverty or increasing one's income level, right? It's about building wealth, and it's about having access to power. And I'll just leave it at that.
Thank you so much. Thank you all for amazing presentations today. We had a really amazing chat happening while you all were talking. And I certainly learned quite a lot, and I'm super thrilled to have been part of this session this afternoon. So thank you again for your insight and your wisdom and for being here today.
Thank you. It was a pleasure.
Yes, thank you for hosting.